Hi, good afternoon, and welcome to Cambia Grove and our 5 Points Conference. Today, we're going to be talking with the patient perspective, and we are thrilled to have everyone here. My name is Maura Little. I'm the Executive Director here at Cambia Grove. Cambia Grove is a health innovation hub focused on bridging the gap between entrepreneurs and the traditional healthcare sector. And we're thrilled to be hosting the 5 Points Conference, which really puts our mission on stage of bridging the gap between entrepreneurs and one of our 5 points, today being the patient. Today we have a little bit of a element that I'm going to introduce Nancy to talk about one of the reports that Washington Health Alliance has put together. Washington Health Alliance is our, let me go ahead and turn off the radio. You hear that too. So Washington Health Alliance, along with UW Commotion and the Washington Healthcare Authority, has been our partners in pulling together the 5 Points Conference, and we are thrilled with their partnership and can't say enough about the community that we've put together and really have built with our partners, so thank you. Today, I'm going to hand over the mic to Nancy. Nancy's going to give a little bit of an overview of the Washington Health Alliance report, and then we're going to go into our panel where we are having Kate Eisler moderate from Daysaver, and she'll run the show from there. All right, so please join me in welcoming Nancy to the stage.
Hi everyone, and it's a pleasure to be with you. And I don't know what number now I've been to these series, but it's great to see so many repeaters and also to see some new faces. So thank you for being a part of this. I'm going to take just a minute to talk about the patient experience survey that we do every other year at the Alliance. And a couple may not know about the Alliance. We're a not-for-profit organization representing all the stakeholders in healthcare. And we represent about 185 member organizations across the state. We're purchaser-led. We work very closely with lots of folks to try to move the needle on health improvement in our state, mostly through transparency and measurement. So that's us in a nutshell. On your seats, you have a document that gives a snapshot of this patient experience document. And we made some copies that I think we'll have at the end that give you a little bit deeper flavor of this, where we actually show rankings of medical groups along this experience. So let me just take it briefly from the top here. First thing that's important is we use a nationally vetted survey to do this work. So this is not work that the Alliance makes up. We do add some survey questions to it, and I think the panelists may have a comment or two about those survey questions, but this is a nationally vetted survey. It's really important to understand that in our parlance, patient experience is very different from patient satisfaction. Patient experience is asking how often or whether something occurs and how engaged a patient was in the care that they are interfacing with their provider around. It's not whether I liked my doctor or the office staff, it's how often did something happen. And if you look at your handout, you'll see that this survey actually looks at 5 composite measures that have to do with things like getting timely appointments, care and information, how well providers communicate with patients, how well providers use information to coordinate patient care, how helpful, courteous, and respectful the office staff were, and the overall ratings. So what we report on publicly, and if you went to our website, wacommunitycheckup.org, you could see the results by medical group. We sent this survey to 250,000 people in the state. Most of this was in a non-electronic survey. It was a mail survey because we don't have a lot of email addresses that come to us from the providers, the health plans that help us create the panel of patients we send to. This is sent to patients who have seen a primary care physician at least once in the 1-year time period that we're studying. So they've had a recent visit with their provider, not 10 years ago or 5 years ago, but within the past year that we're asking about. We then take the data and work with an outside company to do the analytic work in support of our work. And when you look at the document that will be available at the end here and maybe is scattered throughout some places now, we actually take and rank medical groups in our state. So we're identifying those groups in our state who perform above the state average, which is the green bar when you get to this document, average being gray, red worse than state average, and we rank order them. And we're really fortunate in our state that we have 4 medical groups who performed better than the state average on each of those 5 metrics. And I'm just going to mention them to you because it's worth giving them a nod. Evergreen Health Medical Group, Family Care of Kent, Squim Medical Associates, and Astria Health out of Grandview. And I think the thing that's so cool about this from the Alliance's standpoint is these are big and large clinics and medical groups. They're rural and urban, they're across our state, and they should be recognized for the wonderful experience they provide their patients. The other thing that's important about patient experience is that it has empirically been linked to outcomes. So it's not just that when we're engaged patients, we listen to our providers and follow their orders and their guidance to us, we actually get healthier. And that's really important stuff as we all work together to improve health in the state. The last thing I'll mention is tonight we're going to honor these top 4 medical groups that I mentioned to you. We're working in conjunction with the Seattle Business Magazine, who've been great partners for the Alliance for a long time, and they're actually making an award to these 4 top performers, which is really cool recognition. And all but one will be able to be in attendance, so we're really happy to see them tonight and to recognize their great work. Thank you very much, and I think I turn the time now to Kate.
Thank you, Nancy, for kicking us off. My name is Kate Eisler, and I am the token entrepreneur on the panel. And I am thrilled to be here. I have been a part of this 5-point series now. I think this is the 3rd one, and it has been a great series, and it's really insightful to tell us, you know, as entrepreneurs, really how we get access to providers and how we learn how this complex puzzle all fits together. And so I am thrilled to be a part of this and happy to have this great panel today. We have spent a lot of time kind of prepping and talking about this and started late today because these women have such fascinating stories and information to give you. So I'm going to try my darndest to keep us on time. And I would love to have this as a conversation. You know, there's a few questions. They're gonna introduce themselves and talk a little bit about their passions and their place in the patient journey. And then I have some questions, but I do want to involve everybody and give this really a forum so that you find out what you want to know and you have some opportunity to discuss with these great experts we have. Okay? So with that, Johanna, I will ask you if you could kind of kick off for us.
Sure. So I realized, well, when we did the first panel, I didn't sort of explain what my background is. So I have about a 15, 20-year history in working directly with patients around education, programming, behavioral interventions, evidence-based physical activity programs out in the community. And then the last half of my career has been working more in the policy space and working both in the nerdy, wonky policy space. I see some people who occupy that space here, but also working with the people who are dealing with the problems that kind of fall into the medical arena in that space. So I look at this, I have a kind of a different lens from more medically minded folks that will be joining me. So I'm going to give you kind of a broad overview of the patient. I'm not going to call it a point. The patient as the center of our healthcare system for what that's worth and the way it works right now. So we'll talk about who is a patient, how we fit in with other parts of the system, and then kind of what some key priorities are for patients. So patient is just one part of our lives. Everyone here is a patient at least once a year, I hope. Maybe you don't hope, but and our experiences that we bring with us into the physician's office or whatever other clinic it is are really diverse. So we bring a variety of commitments and constraints: family, work, community, transportation, childcare, time as sort of both a constraint and a commodity that we have to think about in our schedules. Diversity, so race, gender, sexual orientation, our language skills, our education level, our approach to how we even think about ourselves as part of the system. And then also geographic diversity. So what we have access to here is really different from folks in Neah Bay or in Yakima or Kettle Falls. So really what we have as an asset and expectation living here is really different. The current state of our system is a great big patchwork. It's set up as a response to different needs in our system. So we start out with family doctor in our little communities, and it's evolved as our innovations around healthcare have evolved, which is exciting. But we didn't really have a plan for how that's come together. It's just sort of happened. It's not designed around the patient or by the patient, because we would probably all have done that differently. But it's been sort of come together in response to the needs. And a lot of times those needs are around finances. And I ran across this fantastic quote earlier today. It's that dollars are not proxy for quality in the healthcare system. But a lot of times right now, that's what we're measuring. So I think we're doing a better job around that, but that is a big piece of what patients experience. And then the other part is that a lot of our care is not in our control. It revolves around the other 5 points, or other 4 points in the system. There are 3 ways we come into the system, either acute or sort of emergency care. So that's, oh my gosh, something is very wrong. Chronic care, so something that has been going on for a long time, whether it's diabetes or a rheumatic disease or a neurological disorder. And then the wellness and maintenance part, which we all experience. And sometimes we're on all 3 paths at once because we are complex human beings. The 3 things that are really important for patients are meaningful choices that make us an equal partner in care, control over what is happening to us, and really understanding that time is valuable, both as an asset for us, but also that we want to be quickly in control of what is happening to our health. Working with providers, our provider is probably the closest point in the system for us. So the person that we trust most is the doctor who's taking care of whatever the most important health need is for us. And if we don't trust that person, we've got a challenge. I talked about this at the first session, that patients don't always think of the health provider system, so the hospital or the clinic, as their provider. We've talked about that here as being sort of the larger point, but the relationship with the individual doctor is really a different piece of the puzzle. And I think the trust piece is really important when we're looking at population health and lifestyle issues. So Nancy, I was looking at some of the questions that doctors need to ask, and I was actually talking with someone yesterday about the drinking questions, and they said, I wonder how many people tell the truth. So you got to think about if you don't trust your doctor, how much will you tell the truth, and how does that relationship then work? Thinking about payers, so really the insurance companies, but also the state as a provider, we're really reliant on them for access to care. But a lot of times we're really confused about what the role of purchasers is, or purchasers and payers. So how much does my employer dictate what health care I get? And then a lot of times we really don't understand what our particular type of insurance plan is. So there are so many different types of employer-based insurance, individual insurance, all of the state-supported insurance. All of those pieces are confusing for people. They don't know what their coverage is. And I think it gets really interesting from a policies perspective when patients want a change, and the state really can't help. Maybe it's a federally regulated plan. For thinking about payers, the impact of payers' efforts to manage costs really has an impact on the relationship with our providers, so what we can and can't get in the doctor's office or that the doctor might prescribe. That can really impact the trust level with the doctor and even with the pharmacy. I don't know if you've ever stood in line behind someone who didn't get what they thought they were going to get at the pharmacy, but it's a shocker sometimes, right? On the policy side, I'm going to preach a little more than I'm going to educate. Maybe I'll educate a little bit. I really believe patients need to be engaged in a meaningful way at the table. And it's really hard to do this really effectively. Patients aren't an organized body. Even within the patient advocacy groups that do policy work, the priorities and the drives from outside of, especially from the local state level, they're really all over the place and not coordinated to sort of make a really strong impact. And it makes it hard for people to reach out and include patients. Adding patients to the conversations can also be really hard for folks that have traditionally been at the table and a little bit scary, but having people at the table who have lived the experience changes how we talk about it. So I remember sitting in a conversation several years ago with a decision-making body where a committee member actually said, I don't know if pain's a valid outcome measure. If there had been a patient on the committee, that conversation would have been very different. The place that I'm really excited about policy is the things that are coming out of PCORI, the Patient-Centered Outcomes Research Initiative, and that they're actually influencing a lot of our federal work. So pieces that are happening with PCORI are being picked up by the FDA, which is doing a great job of involving real live patients with actual conditions being affected by the drugs they're approving. And that's happening too with Center for Medicare and Medicaid Services. Final thoughts. So patients are looking for solutions that give us information that is easy to understand at the right time. We want meaningful choices and control over our health and our health care. And our experience is really valuable. Our lived experience is immensely useful in making the system better. And I think figuring out how to get patients as individuals to the table is really helpful.
Go ahead and introduce. That was wonderful, and I have a whole list of new questions now that you just said that, which I bet you guys do. And so, Robin, can you go ahead and talk and just sort of introduce yourself and talk about what your impact is on the patients?
Sure. So, hi, everybody. I'm Robin Shapiro, and I also am an entrepreneur. I have started a couple of companies focused on the lived experience and incorporating the actual patient voice into how biotech and pharmaceutical companies actually market their products. And I also started Allied Health Advocates, which was the first statewide organization where patients could actually hire nurses not connected with their system to help them navigate care. And also as a co-founder of WASHA, where I'm now the board chair. WASHA stands for the Washington State Health Advocacy Association. And what we do is, number one, we try to raise awareness about what health advocacy is. We teach health advocacy skills to patients, to families, to volunteers, and then we connect people to health advocacy resources in Washington State. So what the heck is health advocacy? Does anybody know in the audience? I'd love to see. There's a lot of controversy over what that is. Thank you, Cynthia knows. It's really helping people understand, support, and assert their choices. And I loved what Johanna said in terms of, we always talk about choice and control, giving people choice and control. And I loved you adding the element of time, because for patients, for people who find themselves being patients, that is critically important. My career really has focused on how do you incorporate the living experience and also look at this whole healthcare system challenges, barriers in a completely different way. And my understanding is that half the audience are entrepreneurs, and so I'm really hopeful and excited about talking about innovation and how to flip on its head how we talk about health, healthcare, and health systems, because I think we can't change what we don't measure. And I think that this study that is coming out in the Alliance work has been really terrific in measuring things from the health system's perspective of patients. And so one of the things we talked about in the room earlier before was, what if we flipped that on its head and figured out a way to fund research and measurement from the patient's perspective? And so I think we're going to talk about that. It's my pleasure to be on this panel with these very fine ladies.
Kellee?
You have to first learn how to use the microphone. So my name is Kellee Franklin. It really is truly an honor for me to be here. And when I mean it is an honor to be here, I mean that with my full heart. And I can tell you what that actually means. So I have been a strategy and innovation consultant for about 20 years. And was clipping along my life as you do, and in 2013 found out that I had triple negative breast cancer. And so that threw me into a patient experience that I was not expecting. And as I tell folks, the interesting part of that, when you are a human-centered design expert, you get thrown into a situation like that, you become the researcher and the rat. Because I was fascinated when I was going through the experience, because while I had consulted to the health industry in a variety of different ways, I had not really been fully dedicated to the health industry. But here I was, somebody who had dedicated themselves to helping clients improve their process and their systems and their products. And I was fascinated, because what I came to understand, while they did a lot of things well, as you might imagine, I found out that they are doing a lot of things that they could have vastly improved. And so I said to myself, as I clipped along this journey, if I did survive, I felt an obligation to be the voice of the patient, because as a human-centered design person, all the other industries that I had been in service of, you know that it is important to keep your client, your customer, and in this case, the patient at the center of whatever you are designing. And I love that Johanna mentioned that we are all patients. And I don't know how many of you are familiar with the wonderful quote from our former First Lady, Rosalind Carter, and I'm not going to do a very good service of that quote here, so please forgive me. But she talks about that there are 4 types of persons in this world. And it revolves around that you're either going to be somebody that needs care, or you're going to care for somebody, and there's 2 other things, and I can't remember, but you can look it up. But it's true. So I lost my father at 22. 20 years later, I became a patient, and now I'm caring for my 80-year-old mother. And so we're all on that journey. And it's my belief that if we as strategy consultants, as innovators and entrepreneurs took that attitude about this industry, we could do wonders. So it is a tremendous honor for me to be here, and I'm glad to have your presence here.
Wow, this is so cool. Now, where do we start? A couple of things. Johanna, I'm going to start with you and think about, you talked about the different ways patients come into the system. And you talk about how they are, at their most vulnerable. Sometimes we did talk about that a little bit earlier today, that, oftentimes you come into the system regardless of where you are. If it's, you are not on an equal playing field with those guys. And you come in and you're looking for expert care is what you really want as a patient. But oftentimes, you're not only sort of outskilled in that area, you're naked. I mean, let's be honest. And so, you're not equal. And so trying to find the balance between how you get good customer service and how your provider keeps you at the center as a customer is a question I have. How do you think about that? And so I kind of want to address that with Robin and with Johanna both.
I don't think I have an answer for you, but I think, so I worked with patients that were in the rheumatology field, And I think one of the other pieces there is a lot of times patients are really well educated and come in with a lot of information that is good, trustworthy information, but they aren't listened to. And so I think that's another component is how do we, and there isn't time to listen to them. Rheumatology is maybe a little different because they need to hear those histories to sort of string together the facts, but how do you make that work?
Advocate as a patient.
Well, that's a big question.
It is.
But I think that one of the things that we do at WASHA is we hold a lot of community presentations to try to teach people this continuum from patient to participant. So patient being reactive, uneducated, and participant being fully engaged in your care. And let's face it, we are all at some time going to be moving across that continuum back and forth, depending on our circumstances, our disease, our personality, our skills. And what I would like to see in the future, this is along the a la if I had a magic wand perspective, is that every person would have a common language about what it means to be a patient versus a participant, and able to understand and access resources for when you slide down to the patient perspective, actually having supports so that you actually get the engagement that you need. So I don't know if I exactly answered that question, but I think that's how you become an advocate.
No, it is. And you talked about on that, how that patient, that sliding scale and what they need and how they move across that. And we talked a little bit earlier about what implications that scale has. And so if you could talk a little bit more sort of contextually about how that affects the system.
Sure. Well, I think what we talked about before, and Kellee can jump in here too, she's had a lot of experience with this, but we actually had a great time right before here chatting about lots of different issues related to this. But you guys might be familiar with Judith Hubbard's research on patient activation measure. I'm trying to see if anybody's nodding. She's out of University of Oregon. And we wondered aloud if the patient activation measure, which basically has 4 quadrants for patients, those least active, so think people not knowing where to start, where to take the first step, versus those who are really engaged and knowledgeable. And what if we had a world where we looked at patient interaction through the lens of where people fell on that 4-quadrant system? How might our healthcare providers work with the patients to meet them where they are? So that was a kind of a question and a wondering, and I don't know if you want to jump in there, Kellee.
What I would say some of the best advice, hands down, and I've offered this in other conversations I've had with health communities. When I was first diagnosed by the nice physician over the telephone, she was very kind, and I did say to her, "What is your advice for me?" And she said, "Actually, I've never been asked that question before." And she said, "Look, you're in Seattle. You're going to get great care." She said, "But find yourself an advocate." And what she meant by that was find a physician who is going to be an advocate for you. And I offer that to you all because I think we undersell the importance of the physician-patient relationship. And I know we live in Seattle, and it's sexy to talk about technology. And believe me, I was at Carnegie Mellon at Health XL a couple weeks ago, and I was all about the robots, believe me. But I think that the further away we get away from the human connection, and we lose sight of what we're really in the business of doing. So I think that's important that we keep that in mind, and I can give you a specific example. So when I had my double mastectomy surgery, and this had been after I had 16 rounds of chemo, so I was a pretty wiped out kitten, if you can imagine. It was clear to me, again, the whole researcher rat thing, it was clear to me that Lean Six Sigma, how many of you are familiar with Lean Six Sigma, right? had been in there because the process was very efficient. I mean, I was in surgery on the table, and I was at home in, I think, lightning speed. But when I was recovering from surgery, a woman from the hospital, I won't name what hospital because I had very good care, but from like quality control came in and said, do you have any feedback for us? Well, I'm kind of groggy and I'm kind of coming out of surgery and my friends are there and they kind of rolled their eyes like they have no idea who they're asking. And I said, well, actually I kind of do have feedback. I said, and I started, giving points about the process and how I felt like it was very inhumane. And I could see her slowly backing away, and she said, well, here's my card, and, I'll get back to you. So I think she was wanting me to comment on the Jell-O. I don't think she wanted me to comment on the process. And so when I had my follow-up appointment with my surgeon a couple days later, I said to her, I'm just curious. I said, when they redesigned that surgical process, did they ever ask you your input? And she said no. So I am shocked, as somebody who's been in this business for a long time, how you could redesign a process that important and not involve the people who are the key players in the process. And so for those of you who are entrepreneurs and strategy consultants, that can be so much better. And I've got more details to that story about actually what happened and occurred that would probably make you gasp, but I don't want to take up all the room here. Yeah, we just have a lot of room for improvement.
I also think that brings up another really good point, which is, and it's going to be no surprise to you, there's a huge disconnect just from a language perspective in terms of what doctors say and what patients hear. And so I think you and we as entrepreneurs could be doing a lot better job of closing that gap. A lot of healthcare is about communications, and I was really delighted to see in the Washington Health Alliance report that communications between doctors and patients improved. So yay, that's great, but it still can be a lot better.
So my question is, how does that input get ingested in the system, Johanna? Does it get ingested?
I don't know how well, I think there's this sweet spot of what's important to a patient and what we're currently measuring, and we're not quite there yet. I think that the piece around so my early years were spent actually working with the chronic disease self-management program and the arthritis self-help program that preceded that, which are really designed to teach patients how to manage their own health care and their own health, not just in the medical setting, but lifestyle components, but also talking to their doctors and talking to their family members about what's going on. And I feel like that piece gets efficiency.
It lost its funding.
Well, it lost its funding.
And it was a great program.
But there's such value in sort of people would just sort of, you walk in with a little more confidence. So how do you build those tools back in? And actually they stay out of the doctor's office a little while longer too. So they're more in control. How do we build that trust for the patient and the skills for the patient to make them part of that process?
How do we build the ability for the organizations to listen to it is a big question, that avenue. And how do they ingest that, and how do they say, oh, these are things that we need to be mindful for? And Kellee, one of the things that we were talking about is, what is your dream then, when you think about the experience you had, what is the optimal patient-centric experience? I mean, how would you have changed that? Timing of when they asked to start off with?
That is a large question. That would probably require 6 more courses. I can tell you where I think some things are going. So Helix Center, how many of you are familiar with the Helix Center in London? So this is a human-centered design, actual innovation laboratory that is actually part of a hospital system. I think that's cool. So they're right on site and integrating data. And we've talked about, I'm on the advisory panel here at Cambia Grove, how to better integrate data and absorb it into the system to make things more applicable to the patient. Those are the things that I think are real. I mean, I was asked, I can't tell you how many times about satisfaction, and I know I am probably on the hit list at the hospital system that I got because I would always add like 3 pages of notes. I thought it was a horrible question. So I adore my oncologist. And when I would have to wait, because satisfaction was always measured against my wait time. So when I would have to wait, and sometimes it was an hour wait for my oncologist, guess what was happening to the person in front of me, what kind of news she was receiving. And I knew that if ever I was going to receive bad news, guess who was going to spend that amount of time with me? So for me, satisfaction had nothing to do with wait time. But again, that's individual, right, per your patient. But I think that we have to be more thoughtful about, again, with data, and I don't want to get down that rabbit hole, but you know, this goes to larger questions around tools, technologies, what information you're giving questions, what instrumentations not only we're building for patients, but instrumentations we're building for physicians, because what you're building for physicians impacts patients. I mean, this gets to a broader conversation around what you're giving to patients and what you're building for the system that supports the patient.
I think any of us who've worked in large companies and interact with customers know how some solutions get built. We have a certain point of view, we bring in somebody to test that assumption, we set up the questions to test that assumption, and guess what? Our questions lead for, to input that validates what we want to know. And what I think would be kind of cool and interesting would be to create an exercise where if the company or system people got out of the way for a moment and actually had a patient-led exercise around what matters to them, I think we might get different data in terms of what the solutions are.
And I want you to talk a little bit more about that in terms of when you started and introduced yourself, you talked about information and research coming from the patient side versus from the institution and the provider side. So can you talk a little bit more about that?
Well, when we were talking in the room earlier today, and we thought about this Judith Hubbard kind of 4 quadrants idea. So what if, instead of measuring the typical things that we measured, we actually segmented patients who are coming into the system and then had different strategies based on where they were? Because we know that, based on her research, that patients in the lower quadrants who move along the scale, so they go from apathetic or not knowing what to do to being a little bit more able to do, that change at the lower ends of the quadrants compared to the upper. So somebody who is relatively intelligent and kind of engaged, moving to super engaged. So at the lower quadrants, making that move actually creates better, more significant amount of health outcome and decreased cost. So I'm just wondering if we use that as a standard instead of just measuring satisfaction and experience, what would happen?
So I was watching with great interest. The rheumatologists were coordinating for a while, looking at a way to do population management within the clinic, and having patients actually fill out all of their stuff online so that the doctor could have a dashboard to look at with them. And they were measuring some of the emotional components, but they were also measuring some of the other things that are barriers like cost. And so if they needed to have a conversation about changing treatment because the patient couldn't, so actually engaging the patient in meaningful decisions in real time, but having it at their fingertips so they're ready to talk about it too and didn't have to waste the time. That to me is sort of an exciting move towards a more, maybe not patient design, but with the patient in mind.
And yeah, I was meeting with someone just before our meeting who's a Seattle U MBA student who met with somebody from the U who's created a scale to measure empathy, both from the provider and the patient perspective. How cool is that? I mean, that's truly innovative, and I think in terms of what we want to spark are those things that for the person who is the patient at that moment is really going to move the needle.
Yeah, and I was at the, if you all are familiar with the Endwell Symposium, it was applying human-centered design to end-of-life experiences. You had individuals like B.J. Miller and the wife of the gentleman, the surgeon that wrote When Breath Becomes Air. The names are too fancy. I can't pronounce the last names. If it's beyond Franklin, I'm at a loss. But I'm going to lose my point here. Let me think of it real quick. Gonna lose it. Sorry. What did you say?
I was saying that.
I got it.
Okay.
Came back to me.
Okay.
Thank you. You just needed to turn on the microphone. I think that there are so many people that are having health experiences now, and they come up with amazing ideas. I mean, we hosted someone here at Cambia Grove, and I brought this up when I was at Carnegie Mellon, and I mean, with really just brilliant people. And I mean, this young woman, I can't remember her name, she literally was duct taping 4 different technologies together to resolve a medical problem she had because it was not being addressed by our current system. And so that's the kind of stuff I get excited about. Why are we not reaching out to these types of folks who are having to navigate through these complex situations and coming up with these awesome ideas, and our innovators and entrepreneurs beyond our expectations? I mean, anything, and I've worked in a large management consulting firm. I mean, we sit in rooms and knock our heads together. We couldn't have even dreamed of duct taping these 4 different technologies together. But you know what? When survival matters, you figure it out, right? And Susanna Meadows wrote this awesome book, if you all are familiar with that. And so another consulting firm I was going to mention, and I have no relation to them, is Cambridge Consultants. They're primarily out of the UK, but they do have a US presence. I think they do a phenomenal job. They have an in-house laboratory. They're building medical technologies, and they test them. They bring in surgeons. They bring in patients. That's the kind of thing that when I think about the way we should be moving forward, and you've got entrepreneurs in here, prototyping, really involving and really engaging people in the process before it goes to product, because you're going to just have a much better result than you would have by just independently doing it without their engagement.
So that brings up a great question. I have one more, and then I'm going to open it up to you guys. So when you think about that, one of the biggest difficulties we as entrepreneurs have, and Robin can speak to this, all of you guys can, is that the ability for us to get that feedback, to open that door and get that feedback within a health system, to say, look, we have a patient solution. Are you interested? I mean, I face it every day. I have a scheduling system that actually sells to the provider and connects the patient and provider calendars. And so the provider has to buy it. The patient wants it. It's a struggle. And so, what's the path there? What are we missing to get into those health systems to validate and get that feedback? It's a tiny question.
It's a really big question, and I actually don't know if I have a good answer to that. I think it's a struggle because what systems are struggling with is to be businesses making money, keeping their patients, keeping their patients within their walls. As we have talked to many health systems over the years from a health advocacy perspective, you know, they're really running fast and hard to stay alive. So ROI is nice, but I think we also need to encourage health systems to take a chance, to use small efforts to pilot and fail. I mean, it's hard to, that whole big F word in healthcare, it's kind of never the twain shall meet. Why would you go and purposely do that? And yet, as entrepreneurs, we are always iterating and failing fast, because that's how we're going to make it better. I don't think I have any brilliant ideas there.
It's a process. So let's open it up to you guys and talk about, because I think, you know, the patient component of this, and we do, lots of us iterate from a patient side. And so I think it's a really interesting conversation. So questions from you guys? Jessica's got a microphone for you.
Hi, I'm Bob Crittenden, and I have a question. You know, we're running with big, huge systems. They are fairly, you know, for whatever reason, they develop their different systems in place for financial or other reasons. You're trying to bring the individual or the patient perspective into it. And I'm just wondering, you know, given the evidence, what are the fulcrums, the places where the wedges we can put in that actually get systems to change? Is there any studies that look at that and what really has made a difference?
So that's a really big question. And I think from, you know, there's values-based purchasing. What I think I would like to see, I'm not going to focus so much on what evidence there's been. I mean, there's lots of different changes that have been tried, but there's no universal, like the checklist manifesto. That's made a huge difference, and yet there are places that don't use that. But what I would like to see is an understanding that health advocacy, meaning this independent voice where patients can actually access someone or some resources that help them give the straight scoop on what their choices are, and I'll give you an example, a personal example. My brother-in-law went in to have a laparoscopic gallbladder surgery a couple weeks ago at one of the local hospitals, and it's supposed to be an in and out kind of a thing. And they nicked his bile duct. And so the surgeon came out and said, I made a mistake. This has never happened to me. We got to open him up. And they did that, and we got there the next day, and his wife had not talked to the doctor because the doctor was unavailable. And he had tubes hanging out of him, and he was looking at a week in the hospital. And I showed up, and I said to the nurse, hey, can they have a printout of his medical records so she understands what's going on and what to expect? And the nurse said, oh, I can't do that. And I said, why not? And she said, oh, it's a HIPAA thing. And I said, I don't think so. I don't think so. Can you tell me more about that? And she explained that, you know, it'd have to go through medical records, and that medical records would get the record to the patient when they were discharged from the hospital. And I said, that can't possibly be. And she said, yeah. And I could tell that my brother-in-law was getting really upset with me questioning. So I went and did a little research, and the law in our state says that hospitals do not have to give patients their own medical records until they're out of the hospital. And so I did a little digging around. And so you're asking about what help the systems can do. I think, honestly, to make available to patients a neutral source of information to help them understand what their rights are, understand, and I've talked to people, they hate that word rights because it sounds very provocative. But I think patients they just need to know. Nobody would talk to her about how much it was going to cost them for the hospital stay. They kept on putting her off. about that. And when she did get a chance to talk to the social worker said, don't worry about it. Well, guess what? She was worried about it. So I think I think innovating from where the patients are and where their families are to get the straight scoop about what choices are would really be helpful.
Given that we have you here, I actually have been thinking about how can we do that, create some of that behavior change through social support. So the state's doing a lot of innovative work around supporting people in their health care and supporting with the sort of the non-medical pieces. There's a lot of opportunity there. I have a friend that just started working for Within Reach, and she was trying to explain as a fundraiser what they do. And it was really interesting to hear, really thinking about that. There's no wrong door for people that are coming in needing a larger scope of support. How do you get both medical and food support and this other piece and this other piece, so that all of the pieces you need to be successful just in the healthcare part, how do we take care of that resource? But I'm also thinking about, you were talking earlier about going in and sort of what we understand of what's coming at us in the medical field, but we also don't retain it. And so I think the system, even if we could figure out how to do retention, something that you get maybe through your medical records or MyChart. My sister got a prescription for something and I said, okay, what was it? Well, I think it started with an I, and I'm not really sure. And she had to go through 2 or 3 back and forths with her doctor to get that information versus there being good notes. And if that information is there, and we have sort of maybe through the Scribe System, someone was explaining the new virtual scribes that are available and how good the information can be. That's a really big opportunity for us.
I think it's a huge question, right? and I'm happy with the announcement that came out of Amazon, Berkshire Hathaway, and because that alone, them announcing that alone, is causing the health systems to think, we're going to have to do this differently. And then did you hear the recent announcement from Apple? So that alone is lighting a fire. And that, to me, as an organization behaviorist, it starts with what's between our ears, right? We've been sort of moving along and sort of trying to deal with these antiquated systems and duct taping and bubble gumming, but that, folks, to me signals we got to do something. And then all you entrepreneurs out here, that's exciting stuff. So it's a little bit like we've got to kind of navigate the ship we got right now, but there's, I think, big change on the horizon just because, and I think with I know my mom was offered the concierge, so there's that movement of, and to me again, and this shows my bias, we're getting back to that personal care, right? So it's that physician-patient relationship. Again, I think people want to get rid of inefficiencies, and I'm all for that. Whatever we can do to get rid of the white noise, and this was the conversation I had at Carnegie Mellon, yeah, let's get rid of it. Nobody wants that. Nobody wants to be bothered with that. But, when we don't feel good, it is so nice to have somebody say, how can I help you? Isn't it? So that would be my input. There might be more questions, I don't know. So, someone may be more educated than me, but Apple's moving in the same direction as Amazon and Berkshire and JP Morgan Chase.
Sorry, my area is in health policy. So on the same topic, I'm wondering what your thoughts are about these announcements with Berkshire Hathaway and JP Morgan Chase and Amazon. And my initial thought was, if this is going to go beyond just saving a nickel out of every dollar, wouldn't it be great if this type of initiative drives companies to look at employee health as an asset and not as a cost. And what does that mean? Because we can measure absenteeism and we can measure presenteeism and we can drive those numbers to an ROI that shareholders will understand, right? But once that's out of, we're talking about, you mentioned social determinants of health. And there are states that are now working social determinants of health into managed care organization capitation rates. So I'm going all wonky on everybody, but I'm really excited about that potential now for entrepreneurs to be able to step in and start filling some of those gaps. As we start seeing unfunded areas, typically these areas have always been unfunded, especially in my world. In my past, it's really the Medicaid world. And so I'm really excited about that. I think there's a lot of aspirational hope to be made out of that. But I'm wondering what you think, or everyone's a crystal ball because none of these companies have, it's too recent. Nobody's said anything yet. They probably haven't figured it out themselves yet. But can you help us dream a little bit in terms of what you think will come out of this or what the best case scenario might look like?
So Apple's opening clinics for their employees and kind of taking that away from the big systems and making it Apple-centric for their people. It's just sort of a quick summary of what that is.
And, we have homegrown here, actually a Seattle U baked business called Vera Whole Health, which, we've seen some disruption in terms of primary care. I think what's kind of cool about these other announcements is that you have such scale, which is incredible. Plus you have kind of a, contained petri dish. So you actually could move a lot of different levers to actually quickly test and see what's working and what's failing. So I'm excited to see what's going to happen. And those employees are probably not very typical of the kind of folks that you work with, where all of the wraparound social issues are such huge barriers. So how do we get at that? I don't know. Hopeful. Oh, I'm an optimist too, like you. But oh.
I just always think with innovation, and those of you who are familiar with the Stanford Design School and IDEO, they bring thought leaders from different disciplines and different schools of thought to look at complex problems. And so for me, the pushback has been, well, what does Amazon and Berkshire and JP Morgan know about health? Well, I'm like, thank God they don't know about health. We've had the health industry looking at health, and it hadn't really gotten us very far. So for me, it's exciting because you often have to invite what I like to say is intellectual diversity, or what Peter Senge says, collective wisdom, to look at complex problems, because sometimes we look at something for so long that we don't even know that the exit, is behind us, right? I mean, the airplane stewards tell us all the time, right? But we don't know that. So I think that for me, it's exciting because it just has us look at a problem that we've been dealing with for a long time through fresh eyes. And I think that, the possibilities for what I think are infinite, that we don't even know the possibility. I mean, I think about Amazon Go. And can you imagine, if that were the possibility for like a health experience with a human touch, because believe me, I'm all about that, but yeah.
So I think I've waffled back and forth with especially the Amazon Berkshire Hathaway, because it's really exciting because they know customer service. They understand the human side, but then they are an employer. And you know what? I worked for the Arthritis Foundation, and they didn't cover orthotics to prevent knee arthritis. So I've been in that was a long time ago. But that sort of like, what did we think about in our insurance design? I think the goals for what they're doing are going to, and the how of implementing those goals are what's going to make the difference in what the outcome is. So
Patients are humans. Let's not forget that. I mean, you guys have all talked about, we're all humans, right, with other aspects of our lives. And I think that that's kind of where we're coming to. Other questions? Wow.
About the arrangement between Diamond, Bezos, and Buffett, a thought that I had was that you take institutional banking and the logistics of Amazon, and then you mix that with the diversity of industries that Berkshire touches, and it looks like a system where they are de-bureaucratizing healthcare within a group of employers. When they dial it in, then it makes sense, given Bezos's history, that they would scale that out over the rest, because you could add in the fourth corporation, the fifth corporation, until you've got every corporation. And essentially, Bezos's history of commoditizing markets means that they are making a pretty aggressive move on healthcare, actually. And what I wonder about that is, what is your views on what the Uniteds and the Kaisers are going to do to respond when Bezos is commoditizing healthcare?
A giant question. Can you guys, from a patient perspective, so I think that that's the hard bit of that. The answer?
I think, so I was thinking about the Apple piece. And so how does that impact? So if you have the Apple Clinic, but you happen to have picked the Kaiser plan and you can't go to the Apple Clinic on campus, like I think figuring out how all those pieces are going to work together, I don't know the answer to your big piece, but when you really when you think about how they're going to have to figure out how to work together, and it is certainly going to make them think harder about how that'll happen.
It is. There's no question.
You know, it's an interesting question that you pose, because right now, a lot of us as patients don't have a lot of skin in the game in terms of paying into and understanding what the true cost and value of our care is. And so maybe it might be one of the only ways that we wake up to understanding really where choices and, am I getting the hook? You know, maybe actually commoditizing care and services will actually really revolutionize patient thought around what is within my choice and within my control. So that's an interesting observation.
And I think you bring up an excellent point. I think, and this goes, and you and I have a similar interest in AI and VR and a whole lot of things, but you know, I think ethics has to be a continued conversation, especially with these larger corporations and the commoditization of things. My interest around the buy and the shakeup is it's going to force historical organizations to, if they want to remain competitive, they're going to have to say, oh my gosh, what are we going to do? And so that's my interest, because a lot of people, when I've said I'm excited about that, they'll say, but that's only for the employees. And I'm like, yes, but it's going to force the other industries to adjust.
Innovate, take feedback, and change. And from the from someone outside of healthcare, I came in, and that's what healthcare is lacking, is that perspective. So I saw a bunch of hands.
Yeah, microphone. So I'm from Premier Blue Cross, and I work on the voice of customer team there. And a lot of the feedback that we get from our customers is, of course, around cost and the high cost, the stress of that, considering that in their treatment path, feeling resistance to getting care because of that. And I just wondered if you could kind of talk about, from your expertise, that role of cost, and wondering if another point to put on the board up here might be something like patents or pharmacy, you know, some of the areas that that we know drive up cost.
Well, I think patients don't understand at all what their benefits are, how much things cost. They Sometimes when they ask their provider or system to let them know, they don't get a straight answer and things change. So it's the very, very savvy patient that even does that. Where can we innovate? I think you guys have done a really, and gals have done a really good job of at least keeping track of where I am on the how much I've spent and how much more I have to spend. I think you need to work with the providers to make sure that there's a discussion. I think we saw that from the report too, that there's really a lack of a discussion up front as to what things will really cost. And I don't know from, because I'm not a provider, I don't know how to change that on their side.
So I don't know how to change that on the provider side, other than that piece that the rheumatologists were doing, actually having a conversation about and tracking medication discontinuation because of finances. I am kind of excited about what Intermountain Health is doing. Intermountain is based in Utah. Nancy, you could talk better about that. They're a massive health system, and they are going to do their own pharmacy make their own drugs, which I think is really an interesting. Having worked in the drug pricing, is it generics? I'm assuming the biosimilars will be a part of it at some point. I would hope, from the space I've worked in. That's exciting to see that maybe we could figure out a way. And then the other company, I don't know very much about them, but I've always been intrigued, is sort of taking that efficiency concept. There's a company over in Bothell, folks that left Amgen, and we're trying to sort of make the process of making high-cost drugs more efficient. That just pharmaceuticals, yeah. How do we make, we come up with these wonderful innovations, and when they go off patent, how do we make them more affordable? Because the difference, I think as a patient advocate, the difference between my two college classmates who won 4 years ahead and won 4 years behind was life and death in the rheumatology space. And so, those innovative medicines they're life-changing and life-saving, but how do we make sure that we figure out how to make them affordable? That's a whole other innovation space that is really important. And
Another 5-point session, 6 points. I think we have time for a couple of more questions.
Thank you, everyone, for being here on the panel and sharing your thoughts. I was listening to the first half of the discussion, and what struck me was we were talking about a lot of measures and quantifying, which is really hard when you're talking about care and empathy. I also hear on the flip side of providers like having too much data putting to them. Everybody has a dashboard these days. I've got too much information overload. Even the patients are seeing too much information. And now we've got new measures. And it's more, I don't know if there's necessarily an answer, but the reflection I have is is there a way to standardize? Is it possible to standardize across measures? I know PAM is one that many organizations use, but it's not universal, or sometimes and I think some of these measures you need thousands of patients, but what if you're a small clinic and you only have a couple hundred people, or you're a startup entrepreneur and you're trying to get some of that early validation? So it's not a specific question, but it's just more about that data overload. How do you figure out which measures are appropriate? Is there a possibility to standardize in this current mess of innovation that we're in?
I think with regard to the PAM, because I've just been so intrigued with it, thinking about it in a more, the PAM has, it's very complicated actually. It's very, very complicated. However, when you boil it down to its essence, it all kind of correlates with confidence. And thinking about patient confidence and how do you make the patient more confident, I think your point about keeping it simple is very important. One of the presentations that I just did this past week at Finney Neighborhood Village was the ABCs of an effective doctor visit. And the central core message of that presentation is create a very simple agenda. So that was one thing. I mean, really simple, like my key concern is X. Here are my 2 other things. Here's my name, here's my date of birth. I mean, if you could only do that, that actually writing down those 3 things from a data perspective has been shown to lower patients' anxiety tremendously. So that, I mean, patients don't know that they can or should do that. That's a really simple thing that everybody could do. Did you look like
I would
jumped in.
concur with Rob, and I was telling the group beforehand that, you know, from my experience, you know, you get surveyed, again, having the human-centered design experience, I didn't really ever find the survey questions to often be artfully designed. And the surveys tended to be like 10 pages. And I can tell you, after either being at a doctor's visit or having gone through treatment, the last thing that I wanted to do was to fill out a crappy survey. And where my passion is being more engaged and involved with people who are and this is just my own leanings, so I put that caveat there, with how you are designing your technologies, how you are designing your processes, how you're designing your experiences, which I know is a different area than maybe some of the things that we're talking about today. But that, to me, is where you can involve the voice of the patient and really change the how, because I think we often focus on, what I was telling the group beforehand, is the what. And I teach this at Seattle U, and I've taught at the UW, you know, and my graduate students will be focused on the what, the bright, shiny objects, right? But I said, if you don't talk about the how, you have missed 99% of the entire game. And so to me, and if you're familiar with IDEO's graphic that shows designing products, you know, they involve users, and it takes a little bit longer, but the sustainability of those products and the process, if you actually involve users in the design of those inventions, supersedes anything else. So I would encourage those of you who are really looking at transforming and innovating and inventing to really get people engaged in what it is you're doing.
So you have me thinking about both the PAM, the patient activation measurement, but also sort of, if you think about not the patient but the health outcome as a product, how are we doing with each visit in moving the health outcome along? So you know, when you go to the airport and they have those things that you push the smiley face buttons, you know, just imagine walking out of your appointment. How are you feeling about the question, I know what I'm going to do next? And I think that is the part of the health outcome doesn't always get moved along, and maybe we aren't measuring. We measure a lot, but are we measuring always the right things?
Hi, I'm Deanna Schutz, and I'm from Grant Thornton, and I'd love to hear from your perspective a different view of the advocate role. So it's, you know, without question, it's very easy, I think, to relate to the scenario where the patient needs help understanding the landscape and how to navigate and guide and the holistic view of providers, services, options, you know, nutrition, whatever it may be. Maybe because this is where I am now in relation with my family, but I'm dealing with a different advocate scenario where the challenge is the fact that some of my family members have blind trust in the single provider that they've had for the last 25 years in the very small town that they live in. And we are trying to advocate there's another way, there's another service, there's another opinion to be had. And so that dynamic, how do you see that dynamic in dealing as an advocate where you're not being looked at as the resource to get the best thing, but rather you're trying to take me away from the doctor I know and trust?
I mean, this is a really challenging issue, especially in the older seniors that we've dealt with in our for-profit and nonprofit business. And sometimes you, as the advocate, you really should be the neutral party. It's hard, especially if it's a family member. But our philosophy is that the person is always in control. So if they want to blind trust their doctor, it's going to be really hard to change their mind. However, you could do some motivational interviewing. And I don't know if you're familiar with that concept. And if you're not, there's a lot of information out there about it. And it basically looks at reframing what the patient's perception of the end result would be. So focus them on what they're trying to achieve, and then ask them questions that basically get them to the conclusion that maybe there's another way. So that would be one specific strategy. Does that help? Okay.
And that's where I think you put your data hat on, since you and I come from a similar field, right? And when I teach this to graduate students, I say it's important that you provide any client, I'll speak from our language, right? Any client, so in this case a family member, valid and reliable data, and also give them free and informed choice, which is what Robin is saying, that they have the choice to decide, but you're giving them information that may raise their level of awareness to say, well, that's not what my doctor's telling me. And so, but you're still allowing them the choice to make the decision that maybe I'll make this other appointment or whatnot. So.
Other questions that we talked about that I'm, when we think about this and we hear innovations have been implemented in all kinds of industries that were difficult, right? So if I'm going to date myself in banking, no one will ever use an ATM. No one will ever use online banking. Hospitality, no one will ever rent their apartments out. What happened there is, from my perspective, as those industries started to have to listen to the patient and started to look at innovative ways to listen to the customers. And so when you think about that, what's the first thing that happens in these organizations when they go, here's an innovative patient idea? What do they do? What's the first thing that comes to mind there? Anything when you guys hear that?
Can I ask you to, I'm not quite sure that I understand the question.
Sure.
So from the organization's perspective, how do we make them listen?
Right, and how do you make them sort of say, oh gosh, this is an innovation that is a patient-driven innovation. This is feedback that we've gotten. How can we assimilate that? How do we look at that?
So I can't comment from the provider perspective, but I think that when you gather people together and there's an increasing number of people who are asking for things and putting pressure on systems, providing feedback, using social media, paying for independent whatever, I think that makes people take notice. And so I would encourage all the entrepreneurs and, renegades out there, because we're all that maybe, to really put your money where your mouth is and voice your concern and do the things, support the organizations that are really going to be looking after the patient voice and creating opportunities for engaging patients and sharing their voice. What I'm constantly surprised by, and at WASHA, we deal with very intelligent and probably nuanced patient consumers who are more educated than most. But some of them don't even understand that shared decision-making, meaning a decision, that you guys probably all know that, but the decision with the patient and the provider having kind of an equal say is really a thing, that there's actually data. Ordinary people don't know that. And so one of the things that we're doing also at WASHA is creating patient stories and compelling, unforgettable stories to help ordinary people understand what it means to choose certain healthcare paths. So we call it magic words. So kind of that unlocking that secret language of healthcare. And again, we're back to communication.
Those are archetypes, like I can identify with this, so I can emulate that journey.
Or even a story that's so unforgettable, once you have heard it, you will never unhear it. And I'll give you an example. Hopefully this will be unforgettable for you as it was for me, which is at Allied Health Advocates, we had someone call us whose wife had been in the hospital for a year. So kind of extraordinary story. And he said that he was surprised because they wanted to pull all of her teeth. She had been in a coma. And he had asked the question, when was the last time you brushed her teeth? And they had never, ever brushed her teeth because, I mean, maybe hospitals do that now. This was several years ago. But maybe because I'm a total germaphobe and really focused on my oral health myself, that story really stuck in my brain. And when it came to visiting a friend's husband who was dying of prostate cancer in the hospital, he had been in there for a couple days. He was at the end of his journey. And he was getting great hospital care, and went to visit him, and it was a big day for him. My friend said, could you go and visit him, because we're meeting with the lawyer at the end of the day, and I'm running around doing all this stuff. So I visited him. I didn't know him very well. And I said, how are you doing? You know, what are you looking forward to today? And he said, well, I'm really excited because we're going to meet with the lawyer, and I'm going to get a shave, which I'm really excited about. And I said, what about your teeth? Because I just couldn't get that image out of my mind. He had been in the hospital for 3 days. And he said no. And I had asked the nurse if that would be possible, and she said absolutely. But if you don't know to ask that, that might not happen. And so trying to create a window for people to understand what's needed, maybe even before they need it, I hope that that was such an unforgettable story that you all never forget that.
And I think that that story, and thank you for sharing that, illuminates and underscores the importance of advocates on your healthcare journey. And advocates can come in a variety of different ways, right? As I mentioned, the story of being told you get a physician that's your advocate. I would later find out after I got through my breast cancer that my own oncologist is herself a survivor. She's never disclosed that to me, and I've never mentioned that to her. You know, it can be a spouse. It cannot be a spouse, right? Sometimes they flake out. Sometimes it can be family members, but it raises the importance of the good work that Robin is doing. Because when my mom had a hospitalization last year, and my mom literally, she's 80 years old, takes no medication, got a tick bite of all things, and it landed her in the hospital. And we were getting her out of the hospital, and the case manager in the hospital said, have you thought about putting her in a nursing home? I said, she was just on a jet ski like a week before. I said, no, we've never thought about putting her in a nursing home. And if I had not been there, and so again, no technology, and this is my point, I'm a big advocate of technology, but nothing beats having a human heart and the empathy and some of the things that Swati brought up. You know, there's data, and we can data it to death, and we can do all of these things, But if you don't have somebody who is championing your journey, you are just a solo soldier sort of marching along. So as we continue to talk about the evolution of how we can improve the health systems, I hope we never lose sight of the human being at the heart of all of this.
Here.
And Johanna, one thing that you talked about, I think that follows along with that a little bit earlier, was you were talking about patients educating providers and the role of that. And I think that's really worth, when we talk about advocacy and we talk about giving, if someone doesn't have that advocacy, getting a provider education from a patient. So talk about that story a little bit, because I think that's really impactful.
Was there
a rheumatologist that had a patient in part of the education for physicians?
Oh, so one of the projects, the University of Washington partners, the rheumatology department partners up with the Arthritis Foundation and brings second-year medical students in for part of their curriculum is actually Introduction to Rheumatology. It's a not-so-blatant sell on the amazing field. But it's also sometimes the first real hands-on opportunity. And what I didn't talk about was actually what ends up happening is, they have the sort of, you go around to the different rooms, they move every 12 minutes. So it's a very intense experience for the students. But they're meeting a patient in every single room, whether it's somebody whose x-ray they're looking at or a knee they're examining or whatever. But they would inevitably kind of stop and halt when they stopped and talked to the person who talked about getting involved with a voluntary health organization where they could get information. But also then there's sort of, oh, I could learn from you. And you start to see this spark on their faces. So there's, I think, room for innovation in the medical training system. I'm also thinking, like, when both of you, going back to how do you create change in the medical system? So there's the early onset start of how do we change the way we train providers. But patients don't often have much of a voice to change things individually. But when they're not wearing their patient hat, when they're trying to solve a problem as an innovator or an entrepreneur, that is actually an opportunity to advocate as well. And so that's why I've been really excited to be involved with this project, because that's where the change comes in. Is I have an idea and I go, oh my God, I would love that. How do I get behind it? And we're trying to figure out how do we solve your problem.
And we're all happy to tell you about our ideas again and again and again. Okay, a couple more questions.
Yeah, hi, I'm Shubha, and I'm actually a researcher, and I do a lot of work around caregiving, and almost like 10 years of my life I've done that. So I hear for a lot of you have been advocating around caregiving issues, but when I hear about innovations, it's mostly around patient-provider, patient-driven innovation. Where is the voice of the caregiver? Because you know that almost 90% of care happens outside the clinic, outside the hospital, and if you take the social determinants of health model, then caregivers are a very integral part in their own process, and even patients and caregivers have to negotiate and take decisions around health. So both from an advocacy perspective as well as from an innovation perspective, where does the voice of the caregiver come into?
Excellent question. And I know that in working in biotech and pharmaceutical companies for many, many years, that was a big question that failed to get a lot of traction because it's not as direct. And so it's not as direct, right? I think it is very important, and I think the voice of the caregiver could really benefit from understanding this health advocacy role. So teaching patients and caregiving pairs how to work together to not only with the provider, but when you leave the provider. I think, that's one of the trainings that we give. It's a 3.5-hour training. Is focused now on family, friends, and volunteer health advocates, and it's teaching the basics of health advocacy. How do you understand, support, and assert somebody's choices and control. It's very important. There's a long way to go.
First of all, I applaud you for the beautiful work that you're doing. That's very admirable work that you're doing. And I think it's critical because when you have a dedicated care provider, such as yourself, what do you think that does for the patient? Right? I often say love is a powerful curative. There's a great documentary that was produced at the end of last year called Heal. Has anyone seen that? If you haven't seen it, I would encourage you to check it out because it talks about belief alone drives positive health outcomes. And if we have somebody that is shepherding us in a very positive way on our health journey, our health outcome is likely to be much better than if we don't. So I'm kind of preaching to the choir here. I don't know what the answer is to get more of people like yourself involved, but having your presence here among people who are innovating is certainly a first start.
It's like a health doula is what we need.
Actually, I was thinking you get a lot of choice when you're getting ready to go have a baby, but there's no other situation where that happens. I'm wondering too if we have a really, what's that? Yeah, it's sort of like,
It's where the money is.
That's true. It's where the money is. And half the time you don't get your choices anyway because things don't work out that way. But I'm wondering if we make a very sharp divide between medical research and innovation. And a lot of the work, there's some really neat stuff happening in pediatric rheumatology and with working with the parents, because in lifelong chronic conditions, that parent might be the caregiver for decades to come. And there's so much diabetes and, cognitive issues, all kinds of space. But we draw such a firm line between medical and innovation. And if you can connect the two, maybe maybe we can start to bring in the softer side of care, the human side of care into the evidence arena.
And the customer service side of care. Yeah. Okay.
So there's a bit of a persistent tug-of-war between the payer and the provider over really who has the expertise, the data, the experience to define what good, air quotes, what good care looks like. But increasingly, the patient having more information, more advocacy, is getting a slightly louder voice in that tug-of-war, and it's kind of joining the fray a little bit. And I'm curious to think, given the research that you've done, given what you've seen from the patient perspective of what good care looks like, how does that definition of good care change when the patient is more involved? Especially given some of the things you talked about the perception of care. And
I'm trying to, it's a really great question. And I think it might be different depending on where you are. For instance, patients looking at end-of-life care, for instance. For some patients, good care is actually less care, dying at home, being surrounded by people that you love and feeling in control versus having a lot of treatment and that kind of thing. So I think that I think it really depends on where you're coming from and what your goals are, and even being aware of what you want. I think most patients go into a situation not even understanding what they want, because you're diagnosed with breast cancer and then they're saying in the next breath, this isn't your story, but I've heard the story of other people, and I haven't had this experience, but, well, let's get you in for a biopsy, and I think next week will work. And, for patients, often what happens is what's happening is just you're kind of going down the stream. I don't even think you sit back and say, well, what would good be to me? I don't even think there's an awareness of that at this point.
Yeah, I think it's an outstanding question, and I think that Robin's answer is very human-centered, design-esque. It depends, right? So when I was diagnosed, I can just tell you from my experience, the advocacy of having a physician that, you know, we were in a great dating relationship, right? I felt like I had a partner. And I, believe it or not, for as research wonky as I am, I really wasn't interested in surfing the internet and solving my cancer treatment options. I felt like, okay, that's her gig. What I was more interested in was sort of getting squared spiritually. And I felt like if I was square that way, it really didn't matter what the outcome was. Now that was great for me, and I felt at peace with that. But, you know, there's other patients who, you know, have to be down in the granular level, knowing every single thing. I mean, people even asked me today, well, what medicine were you taking? I have no idea. I just know that it worked, and I was happy that it worked, you know. So I think that is what makes this such a complex thing, and I feel for the physicians, right? Because we are so individualized, have individual needs, have individual desires for the experience, and that's where I think exposure to human-centered design philosophy and concepts can be beneficial, because it really is having a sit-down conversation with your patients and saying, how can I best support you?
I think too, there's that space with the provider, but there's a whole other piece when you add the payer into the system, and that, and I think about this from a space of chronic lifelong care, where you're on something that your insurance company may very well not want to pay for because it's expensive. So you're probably not going to get in this debate with hemophilia, but for, you know, psoriatic arthritis or rheumatoid arthritis, that may be a constant ongoing challenge in the relationship with you and your health condition, and your relationship with your provider and your insurance company, trying to figure out how do I manage this when, you know, these roadblocks keep coming up. I always wondered what would happen if, so there these brilliant innovations, the people that work for insurance companies there's so much intelligence and thoughtfulness about how we could do things in a better way, but it doesn't always work for the individual patient or for the specialty populations. And what would it look like to really consult with those, especially those high spend groups?
I was, I mentioned to you I'm writing this book, Magic Words, The Secret Language of Healthcare. And so I'm interviewing people who are contributors, and one person mentioned this word, which I had never heard before, which was financial toxicity. Have you all ever heard that word? And it's basically, you know how chemo and radiation can be physically toxic? Well, there's a financial toxicity to some of the healthcare choices that we make. And who knew? I mean, I didn't really ever think of it that way, but I think it's an interesting framework for, again, having choice and control in our healthcare decisions.
I want to thank you all. This has been an amazing discussion. And you know, in the complexity of healthcare, we've talked about a lot, and we get all of these perspectives. To really sit down and think about personal, you know, we're all humans, we're all patients. To really bring that home and talk about those perspectives and those memorable moments is extraordinary to give us that perspective. So thank you for that. And if I just want to kind of open it and go over time just for a second and say, you know, is there any last thing? Because I think, you know, as we talk about empowering patients and patients' perspective in healthcare, healthcare wouldn't be happening if there wasn't a patient. And so I think sometimes we sit back and go, oh yeah, you know, let the provider. This is extraordinary. So any last thoughts from you guys in terms of how this fits to the puzzle, or thoughts about, from an entrepreneur standpoint, how we can make this, you know, this voice of the patient louder and more impactful in that complicated big system?
As a fellow entrepreneur, I say just do it. Please, please do it. Try to include the patient, innovate, keep at it, don't give up. It's really important. It's vital. What you're doing actually really matters and can save and change lives. So please don't give up.
I'm thinking maybe the question we should be asking is, got human? Or are we using common, are we using common human sense?
I'm going to pull from the late Billy Graham, since we just lost him, and he lived 99 years. That's amazing. But one of his quotes, I'm probably not going to be exactly accurate, but he said, we can't control the longevity of our life, but we can control the depth. So I would love for us all to think about that as we walk our paths, because we can't control how long we're here, but we certainly can control how we offer ourselves and our gifts to one another. So thank you for hosting this, and always your great hospitality. Thank you.
Perfect. Thank you, ladies. Drinks, that's the easiest part. Drinks, celebrate.
Is this on? Perfect.
Thank you, Moira. I'm Tony Blau. I've been a professor my whole life, but I started a company called All for Cure. Our small but mighty team's back here. And it's a big day for us because I think our company's all about the topic of the 5 points discussion today, the patient. And we are building a knowledge sharing platform for patients, clinicians, and researchers for patients with cancer, starting with a form of cancer called myeloma, a blood cancer that I myself happen to have. So, in the last few days, we've created dashboards. We have about 250 myeloma patients that are participating, about 450 people in total, but we create these really cool visualizations that are dashboards. I don't know if I could just show this for just a second, Moira. But we've created our 100th patient dashboard, and it's super cool, and I'll show it to you just for a second. And I'll get this. So we were in the New York Times a couple of weeks ago. If you go to the New York Times and look up All for Cure, you'll see me laying on a gurney and a needle being stuck in my butt as I got a bone marrow biopsy. So you might look for that. This is the last 2 days of a crowdfunding campaign that we have on Indiegogo. I just make sure that I'll mention those couple of things. And then Madeline, thank you so much. And then I think I can hook it up right here. Oh, that's not it. So yes, and I should just say how much we appreciate being here at Cambia Grove. You know, we meet here every Monday, Wednesday, Friday, our small but mighty team, and and free space, free coffee, lovely environment. It's really been terrific for us. And I just thought I would snatch the opportunity talking about patients, our 100th patient having created a dashboard. So our motto is all for one and one for all, bringing the world's expertise to bear on the problems of individual cancer patients, and then using what happens to those patients to help teach the world about how cancer works. This actually is based on a clinical trial that we started at the University of Washington for metastatic triple-negative breast cancer about 4 years ago. But now we're focused on myeloma, not just because I have myeloma, there are other reasons I could get into. But I'll show you for a moment just a couple of things. So from each patient so you can register if you're a patient, if you're a clinician, or if you're a researcher. If you're a patient, you also allow us to access all of your medical records. And from the medical records, we create a visualization of your experience with cancer and we show this graphically. So this is a graph that, what you'll see in a moment is a graph that depicts my experience with myeloma. This is me, you take away my name, you put in this number, and you show here, then by hovering over this, you can see all of my treatments, all of the responses. You can click on or off different labs. We have 100 of these things now. And then beneath this is a summary and a discussion panel where every other participant, be they other patients, clinicians, or researchers, can see what's happened to me and make comments. And so I'll just show, we have lots of cool stories behind this, but one story that I'll just share, and then that's it, is a lovely 61-year-old, recently retired Alaska Airlines flight attendant who developed myeloma in 2016. Terrible risk factors, terrible genetic features of her myeloma. She was treated, these myeloma markers went down. She was sent for a transplant at Fred Hutchinson, an autologous transplant, and then an allogeneic transplant from her brother, who was a match because she had terrible cytogenetics. But before she could get her transplant, she developed this terrible complication of myeloma cells in the cerebrospinal fluid, a miserable, terrible complication. It happens in about 1% of patients. So they tried to clear them by giving intrathecal chemotherapy, and they couldn't. And so they sent her back to her oncologist saying, I'm sorry, we can't help you. And so we sent out kind of a call to our experts to find out, could anyone come with a suggestion that might be helpful to this patient? This is a recommendation by a chief scientific officer of a CAR T-cell company where they didn't think she'd qualify for their clinical trial. This is Bill Benzinger, a myeloma expert at Swedish Hospital, posting a comment. And then this is a comment by Dr. Ken Anderson, who's probably the best known myeloma expert in the world from Harvard, suggesting an experimental drug that they had shown just 2 months prior to clear the myeloma cells from the CSF of 2 other patients with exactly this complication. So we weren't able to get that drug from Celgene because it's an experimental drug, but we were able to, she did get treated according to Bill Benzinger's suggestion that did clear the myeloma cells from her CSF. She was able to get an autologous transplant and an allogeneic transplant 2 days after Christmas. So it's kind of, the point is not just that we're able to bring a smart suggestion to this patient's care. The point is that Ken Anderson making that suggestion for one patient over the phone to the oncologist affects one person. Ken Anderson's suggestion in a platform of eventually thousands of patients, clinicians, and researchers, with everyone having visibility into what's going on with everyone else, has a potential for a massively amplified impact. So, and then just the last self-serving thing I'll say is we have 1 day left on our Indiegogo crowdfunding campaign. If anyone's interested, we'd love to have you. You can see that on our website. The link to that's right here. So thanks very much.